afternoon, everyone, and thank you for joining us today. My name is Robbie Lunt, and I'm the Director of Marketing at Biodesix, and it is my pleasure to introduce our program today called Cancer Can't Wait, Nodule Evaluation and Early Lung Cancer Diagnosis during the COVID-19 pandemic. In today's presentation, our panel of lung cancer experts will cover a variety of topics related to lung nodule management and lung cancer diagnosis. There will be a Q&A session at the end of the presentation to address any questions that you have, so please enter those questions into the Q&A window on the right side of your screen. And without further ado, I'd like to introduce our first speaker today, Dr. James Jett, Chief Medical Officer at Biodesix. Dr. Jett?
Thank you very much, Robbie. I'm a pulmonologist, practiced at Mayo Clinic in Minnesota and National Jewish Health in Denver for about 35 years. My interest throughout my career has been in lung cancer diagnosis and treatment. So my job today is to cover the first bullet point here, lung cancer during the COVID pandemic. The second speaker, Dr. Osarogiagbon, will cover early detection and time to diagnosis and treatment. He'll talk about detection programs in his program and the effect of pandemic on the Baptist Cancer Center in general. So that will be followed by Dr. Steve Springmeyer, Chief Medical Officer for Biodesix. He'll be talking about lung nodule evaluation using telemetry and biomarker testing. Next slide, please. So COVID stands for Coronavirus Disease 2019. That's the name of this disease and epidemic. The first cases reported in December 2019 in Wuhan, China. The first official case in the US was diagnosed in Washington State on January 20th, and the numbers increased rapidly following that diagnosis. The first case in New York was diagnosed on March the 1st this year, and again, rapidly increasing cases there. On March 11th, the World Health Organization Director General declared that COVID-19 was a pandemic. It was now present in 114 countries. So shortly after that, the various states started shutting down in the US into a lockdown situation to try to prevent the spread of the disease. And then following that, a number of medical societies began issuing guidelines. Next slide, please. One of the early guidelines came from the American College of Chest Physicians from an expert panel that issued a report on management of lung nodules and lung cancer screening during the pandemic. It's appropriate to defer enrollment in lung cancer screening and modify evaluation of lung nodules due to the added risk of potential exposure and the need for resource allocation. They were afraid that they were going to need those operating rooms, procedure rooms for COVID cases. Next slide. The American Association for Bronchology and Interventional Pulmonology issued a statement on bronchoscopy and respiratory specimen collections. They said that bronchoscopy is relatively contraindicated in suspected or confirmed cases of COVID. Bronchoscopy for elective reasons should be postponed, and bronchoscopy for urgent or emergent reasons should be considered only in life-saving situations. They had other guidelines and points that they made, but those were the main ones. Next slide. The Thoracic Surgery Outcomes Research Network then came out with guidelines for triage of operations for thoracic malignancies. They suggest that surgery be restricted to patients whose survivorship is likely to be compromised by a surgical delay of 3 months. Then they said surgery should be deferred for 3 months. They estimated 3 months on solid nodules and lung cancers that were less than 2 centimeters in diameter. Again, I think they were thinking that this pandemic was going to pass in about 3 months. Well, that proved not to be the case, as we know. They recommended deferring patients that were likely to require prolonged ICU needs, so that we did not take up the ventilators and the patients that were likely to be needed for COVID, and that all thoracic procedures typically scheduled as routine or elective should be deferred. So these were statements, the references are at the bottom of those slides, by some major organizations. Other organizations also issued other guidelines. Next slide. Now, move forward a couple of months. Whoops, I think we're in the wrong one there. Can you go back one? Next one. Next one. There. So in this editorial by Dr. Norman Sharpless, who is director of the National Cancer Institute, he said, well, obviously what we all know, in general, the earlier one receives cancer diagnosis and treatment, the better the results. But he noted that there had been a steep drop in cancer diagnosis in the United States since the start of the pandemic. And that the actual incidence of cancer obviously has not dropped, but the cancer diagnoses have certainly dropped. Modeling at that point in time already had suggested that over the next decade, there would be 10,000 excessive deaths from breast and colon cancer alone. Now, that analysis was conservative, he pointed out, because it does not account for other cancer types. So this was an editorial in Science in June already. Next slide, please. So Kaufman and colleagues published this paper in JAMA Network, Open Network, where they looked at the changes in the number of new diagnoses of cancer during the COVID pandemic. They did a cross-section study of the Quest Diagnostics evaluating ordering physicians' code for new cancer patients for 6 types. Those types were breast, colorectal, lung, pancreas, gastric, and esophagus. So they looked at a period from January 2018, before the pandemic, all the way up to April of 2020, which was obviously during the pandemic already in the US. Each patient was counted only once, and they looked at weekly counts that they tracked. They concluded that the pandemic weekly number of new cancer diagnoses had fallen by 46%. Instead of 4,300 patients per week before the pandemic, they were seeing 2,300 patients for these 6 cancers. There was an approximate 35% decline in lung cancer diagnosis, 52% decline in breast cancer diagnosis, and 25% decline in pancreatic cancer diagnosis that were observed. Then, next slide, please. Now, the study out of the UK, Maringe and colleagues, published in Lancet Oncology, looked at delayed in diagnosis in England, in the UK. So that obviously the UK had a national lockdown due to COVID, just like the US. They suspended cancer screening and routine diagnosis. Only urgent symptomatic cases were prioritized. And they looked at the delay in 4 cancers: lung, breast, colorectal, and esophagus. They reported that there was going to be an additional 3,200 to 3,600 deaths from these 4 cancers over the next 5 years, and that these additional deaths would result in approximately 60,000 years of life lost from just these 4 cancers due to these delays. Next slide, please. So Oncology Live did a survey of 51 oncologists in the US in early May. 73% said they were limiting surgeries to urgent or essential cases. 53% said they had modified dosing of chemotherapy regimens to reduce the need for inpatient visits, or in-person visits, 71% had canceled routine office visits in oncology. But 57% said that they thought their practice would return toward normal pre-COVID levels in 6 to 12 months. Well, in retrospect, that's probably optimistic. I think with the surge in diagnosis that's going on now, while oncologists are seeing patients, I'm not sure that they're going to get back to the pre-COVID levels yet this year. Next slide, please. So the modifications that they had seen that oncologists were doing, they were doing more telehealth visits. They were doing drive-through services for laboratory and injection services. They were having patients check in remotely, just like my dentist did for my last dental routine dental care 2 months ago. They had patients wait in their cars until they were called in and the physician was ready to see them. Now, if you know the wait in some doctor's office, that could be a pretty long wait. I hope it wasn't too cold outside in their car. But nevertheless, the safety precautions, I think, were being taken. Next slide, please. So we're losing ground during the pandemic. We're having delay in screening. We're having delay in testing and diagnostic procedures, having deferrals of surgery for cancers. We're having deferrals and interruption of chemotherapy. And then clinical trials have been delayed. I think clinical trials were probably shut down for at least 2 or 3 months. Some of them still aren't back up and going at the normal pace, but they are resuming. So next slide, please. So this picture comes directly out of this paper, which is an excellent review called COVID-19 Cancer, Current Challenges and Perspective by Balkuni and colleagues, published in Cancer Cell. And they noted the disruption in cancer care to patients and providers. It affected funding, so philanthropic funding decreased. There's decreased foundational grants. NIH supplements and revisions are being shifted. There's a decrease in research with COVID-19 taking precedence in a lot of laboratories. There's effect on patient care that we already talked about. And then there's these personal stresses. I don't believe you can read that there, but obviously there's occupational risks of acquiring COVID for the providers. I just heard that 900 providers just in the Mayo Health System in the Midwest have come down with COVID. 900 providers there. So there's a risk of protective equipment concerns and others. And then the stresses related to the kids being home now, being taught online, and mom or dad needs to be around and helping with those things. And now mom and dad are distracted from their work in the medical field. So next slide, please. So part of a response from ASCO, the American Society of Clinical Oncology, came up with this coronavirus resource, a special report and a guide for cancer care delivery, summarizes some changes in policy and practice that they suggest. ASCO guidelines address best practices and scheduling telemedicine. Providers suggested when and how to establish screening and surgery. ASCO also has developed this oncology registry. This is for doctors. It's not for individual patients, but doctors can enroll their practices. So they're going to try to evaluate how COVID-19 impacts cancer care and patient outcomes. So far, over 50 practices across the U.S. Are listed as participating in this COVID-19 registry in oncology patients. Next slide, please. So the last slide here, this paper just came out 2 weeks ago in the British Medical Journal, looking at mortality impacts due to cancer treatment delay. This was a meta-analysis. They found 34 studies of high quality related to 7 different cancers. Those cancers were breast, lung, colon, rectum, bladder, cervix, head and neck. The main outcome of the study was to look at overall survival for each 4-week delay in treatment. So the delays were measured from the time of diagnosis to treatment. So you have a bronchoscopy, you get a biopsy, it shows lung cancer, the clock started. How long of it until surgery? Was it 1 month? Was it 2 months? They also looked at completion of one treatment to the start of the next treatment. So the association between delays and increased mortality was highly significant. The mortality risk for just a 4-week delay in surgery was 6 to 8%, just for a 4-week delay. Now, what about an 8-week delay or a 12-week delay in surgery? Well, you can do the math and you can see how those numbers add up very rapidly. So delays are not good. For some of the radiotherapy and systemic treatments, delay resulted in mortality, 4-week delay resulted in a mortality risk of 9 to 13%. So these are just delays related to treatments. The study did not address the delays in diagnosis. So they didn't just say, okay, you do a mammogram, you find a spot on the breast, suspicious spot. What's the delay until a biopsy? Or the spot in the lung picked up on a CT scan? The delay to time of diagnosis with bronchoscopy or a transthoracic needle. So we don't know what impact that has on mortality. This study only addressed the delays in treatment. So with that, let's go to the next slide, please. I'm going to turn this over to the premier speaker in this program, Dr. Ray Osarogiagbon. Ray is a medical oncologist and head of the thoracic oncology program. He's also the chief scientist at Baptist Memorial Healthcare Corporation in Memphis, Tennessee. Now, a number of you may know Ray, but what you don't know about Ray, and I'm going to tell it, Ray, okay, is that he is a Shakespeare aficionado. He has attended courses in Stratford-on-Avon, which is the hometown of Shakespeare. Now, I don't know which Shakespearean character Ray's going to do today, but I've known him to kind of reflect Richard III on a number of occasions. So, Ray, take it away, buddy.
Oh, good, Jim. Good evening, everyone, and thank you, Dr. Jett. Jim is such a champion. Jim, I would like to acknowledge as the if I had to name one person who I would identify as the mentor of my career in thoracic oncology, Dr. Jett, without any hesitation, without any shadow of a doubt, would be that person. So thank you, Jim, for your advocacy, your friendship, and the love you have shown me all these years. And thank you to Biodesix, Steve Springmeyer, and colleagues for the honor to participate in this program this evening. I'm a thoracic medical oncologist in Memphis, Tennessee, and I'm going to just tell you a little bit of our past and ongoing experience and the strategies we have adopted to deal with this wicked challenge that is lung cancer and the superimposed wickedness of COVID on that challenge. Next slide, please. So lung cancer, I think the news, I think of late had been good. We were all excited about the reports of the sequential reduction in the incidence of lung cancer, and hand in glove with that, sequential reduction in the mortality, deaths from lung cancer for men going back to 1990, for women since the 2000s. Great news, what we want to hear. The problem is that is aggregate information. And what this slide demonstrates is that when you begin to fragment out geographically, you see very quickly that the news is not uniformly good. So in Memphis, Tennessee, in a state, in a catchment area, in a healthcare system that includes parts of Mississippi and Arkansas, even parts of Southwest Kentucky and Northeast Alabama, I don't really feel that excitement that everybody talks about. Next slide, please. And there is, of course, no great mystery talking about lung cancer, why that map is the way it is. This is the active smoking map of the United States. And you can see how almost superimposable both are. on each other. Next slide, please. And when you go even deeper to the county level, the news is even more disturbing. So here is the county level lung cancer comparative mortality map of America, where we are now comparing the per capita mortality of lung cancer change from 1980, where you expect it to be higher if the aggregate news is uniformly applicable, to 2014, where you would expect it to be lower. Now, the color bar at the bottom kind of gives you the key to this map. On the left side, where things are green and dark green, yes, indeed, that's exactly the story. Striking reduction in mortality, in per capita mortality. Unfortunately, if you look to the right, where it's pink and red and purple and deep purple, unfortunately, there are counties in the United States in which lung cancer mortality has continued to rise. And unfortunately, next slide, my catchment area counties are very much in those places. Now, we know that screening for lung cancer saves lives. We're very excited. The National Lung Screening Trial results were, published in 2011, and the news has been great. The Nelson trial from Europe came in and corroborated what we found in the United States. So we know we didn't lie to each other. Indeed, somebody has shown it to be. Now we know that screening, low-dose screening CT has to be wrapped within certain things in order to make it safe and likely effective. And one of those stipulations has been accreditation by the American College of Radiology as a screening center. Now, if you just ask the question, where do those screening centers exist in the United States? How are they arrayed? You see a striking VQ mismatch. So that deep red heart of the US lung cancer mortality belt is not where you see the deep blue density of radiology screening center deployment in the US. So unfortunately, what we're quickly finding is that as discovery leads to knowledge of benefit, disparities begin to show their ugly head. And we already see that with screening. Next slide. So my healthcare system, the Baptist Memorial Healthcare System, is a community-based healthcare system. Community-based healthcare systems are the places where 85% of lung cancer care is delivered in America. If my healthcare system, with an annual lung cancer volume of 12 to 1,300 over the last decade or so, were arrayed out on a state leaderboard for lung cancer incidence, we would be number 39 of 51 states, with more annual lung cancer cases than the states of Utah and New Mexico, the Dakotas, and on and on. Even some states that have comprehensive NCI designated cancer centers. So one of the challenges that I have had to deal with is helping my healthcare system leadership understand we are not small. And you cannot take the idea that you're only a community healthcare system to be an out from the responsibility of delivering high quality care to a high need population. Next slide. So we came up with an ambitious goal. I sold to them the idea that over the course of 10 years, we could bend down the lung cancer mortality curve in our 107 county service area population, which is right at the heart of the US lung cancer mortality belt. 25%. What does that get us? So the lower line is what is projected in the US in aggregate, going with the current momentum of lung cancer mortality reductions. The upper line is where my service area county population is headed if we don't make a change. And red is what we have projected if somehow we're able to deploy life-saving programs that bring patients in and somehow transforms mortality at the population level to reduce it by 25%. You see, all we get is to become parallel to the US. We're not bending down to catch up. We're just trying not to fall further and further behind. Next slide. So we decided we would take a very intentional programmatic approach. The problem with lung cancer, as everybody knows, is that by the time we diagnose it, too often patients are too far in their disease spectrum, and we're now talking about palliative and modestly life-extending treatment with really no great promise of cure. Now with screening, we have the opportunity to deploy an intervention that can capture the disease early enough where we begin to rescue people from the threat of death. But one of the other things that we also have emphasized as a key strategy is that, my goodness, we sure do a lot of radiologic studies in this huge community healthcare system. And my word, quite a few of them show lesions that in fact could have been lung cancer or actually turn out to be lung cancer. And oh my word, too often we actually find the cancer that we can track its natural history. We had multiple opportunities to intervene and we failed to do so. So right about the time that we started building out our low-dose screening CT program, which is for ostensibly healthy people who are a certain age and have a certain smoking history, we concurrently started a program to identify patients with incidental lung nodules and manage them using evidence-based standardized tools. And this slide just shows you the number of individuals who have flowed through both programs. The green line, the upper line, is people who have come in through the Nodule program, people who have had an X-ray for any reason, car accident, heart attack, pre-op, whatever, showed a lesion, captured by EPIC, and put in a queue for our multidisciplinary team to triage into the high-risk ones get more attention, the low-risk ones maybe could be discharged. And then 4,225 patients who have gone through the screening program. Next slide. Actually, next, just hit the next bar. There we go. So one of the things to point out is that although we're excited that lung cancer screening saves lives, even if 100% of eligible patients in the United States participated in low-dose screening CT, you would still only identify the minority of lung cancer patients every year. Why is that? Because our eligibility criteria are imperfect. They are, in fact, so imperfect that it's the minority of patients who would qualify. In my healthcare system, looking at the lung cancer patients we have diagnosed through the Nodule program, only 33% of them would have qualified using the current Medicare criteria. Now, those criteria are going to change starting next year. They're going to loosen a little bit, but that's where we were. Interestingly, when we look at lung cancer patients diagnosed through the traditional way, meaning they didn't come through one of our early detection programs, it's the same thing. 33% would have qualified. These guys, majority of them, would not have been eligible for screening. Next slide. So with the two programs, we have identified a lot of lung cancers cumulatively. Very interesting, although the low-dose screening CT patients are ostensibly at higher risk because of the eligibility criteria, for every one lung cancer patient we have found through the screening program, we have identified 5 lung cancer patients through the Nodule program. The point I'm making here is that these two programs are complementary. And if, as in my system, our goal is to bend down lung cancer death at the population level. We can't insist that we're going to do one and not the other. You really have to do both. Just hit the advance to the next thing. Yes. And in my high-risk region, although the National Lung Screening Trial revealed that it was 1.1% of patients who were ultimately diagnosed through LDCT with lung cancer, in my healthcare system, my population, it's 2.6% of our screened patients and almost 5% of our nodule patients who are being diagnosed with lung cancer. Next, hit the next thing, please. And this just shows you that, yes, indeed, we seem to be achieving the desired goal, shifting the proportion of lung cancer patients diagnosed at early stage to become the majority. Whereas traditionally, it's only about 15% of lung cancer cases that are diagnosed at stage 1 and 2. With our screening program, it's about 63%. With our nodule program, it's about 56%. Next slide. So we are excited. We started this program in Memphis. We are now scaling it up across our 3-state healthcare system. And you can see where fiscal year 2018 in blue, 2019 in red, and 2020 in green, you can see how our numbers of people being screened was ramping up very rapidly. And then, of course, we hit March, April, and May when COVID hit. And then suddenly, not knowing what in the world we were dealing with, we started shutting things down, and patients, in fact, also autonomously shut things down. And you see how our lung cancer screening volumes plummeted. And then when we got a little bit better understanding that lung cancer is not an elective, diagnosing, staging, treating lung cancer is not necessarily an elective thing, we were forced to begin to figure out ways to reopen the services as we started seeing people coming in with way more advanced disease than what we would have liked to see. Next slide. Also, with the nodule program, you just looking at the last 3 fiscal years, once again, you see the pattern as we were building out the nodule program, first in Memphis and disseminating it into other parts of the healthcare system. We were beginning to see the numbers go up year over year. And then, of course, we hit March and the numbers just plummeted. Once again, we have learned very painfully that lung cancer can't wait. You can't shut these programs down. You will pay a steep price. We are already seeing that in some of these people in whom, unfortunately, we are once again tracking the natural history of undiagnosed, untreated lung cancer. Next slide. Now, of course, when you diagnose, if you just advance this slide all the way to the end of it, when you diagnose lung cancer, you have to make the right decisions. You have to figure out which of these lesions needs intervention now, which one can be monitored, which one can be discharged. It takes multidisciplinary decision-making to do it safely and effectively with pulmonologists and surgeons and even medical oncologists, certainly with radiologists and pathologists and so on. This is one of the challenges we have taken on in my healthcare system. Next slide. And this idea of going from a fragmented referral-based system to one where you have this population-deployed programs that feed into a multidisciplinary decision-making arena is one that we have shown in the next slide. Definitely saves lives. So this is a slide from a paper I presented at ASCO this year. It was an oral session paper that basically shows survival of patients who received their decision-making, not care, decision-making within our multidisciplinary program. In this case, defined as a rigorously deployed conference model in blue, compared to patients in metropolitan Memphis within my healthcare system who, although they had access to the multi-D forum available to them, somehow their doctor chose not to bring their case for discussion. You see their survival. And then in green, my healthcare system being deployed across a predominantly rural region, patients within my healthcare system who got their care in the regional components of our healthcare system are bringing up the rear in green. So multidisciplinary decision-making saves lives. The point is, as we deploy these early detection programs, we have to feed them into a multidisciplinary forum where the right care at the right time gets delivered to the right patient. Next slide. So ultimately, the goal is to push stage down to earlier and see a smaller and smaller proportion of patients come in at advanced stage. So if we narrow the lens to our multidisciplinary program in this community-based healthcare system, you can see that over the last 5 years, we're seeing trends in that direction. So the proportion of patients with stage 1 in blue, in dark blue, has been sequentially going up. And the proportion of patients in stage 4 in the lightest blue, I don't know if that's called teal or what, is sequentially going down. That is exactly what we want to be able to see sustained all the way going into the future. Next slide. And I will just wrap up by saying, if we're going to bend down lung cancer as a burden of mortality at the population level, early detection is the name of the game. We need prompt, appropriate, safe intervention to diagnose early, safely, to stage, and then to optimally treat. And it requires the right treatment for the right patient at the right time. Thank you.
Thank you, Ray. That's excellent. I'm Steve Springmeyer. I'm also a pulmonary critical care physician. Been working with biomarkers for about the last 5 years, so I'm pleased to be here this afternoon. Let me take a moment and remind you, if you have questions, please go ahead and enter them, and we'll have time at the end to address questions. So what are we going to do? Cancer can't wait, but we don't want unnecessary exposures for ourselves, our friends, our staff, etc. So that's leading to more and more telemedicine. And we have a blood-based testing scheme that's working out well with remote evaluations. Next. We're going to talk about the millions of nodules that are found each year. As Ray's pointed out, only a minority are cancer, but we have to find those. Unfortunately, our assessment of the pre-test risk of cancer are not accurate. So what happens is malignant nodules go to CT surveillance, and that is a risk of delayed diagnosis. On the other side, if you go ahead and evaluate them, you end up biopsying or doing surgery on benign nodules, which in hindsight could have been avoided. And recent surveys, an average of 35% of surgical resections find benign disease. Now that's not always wrong, but a lot of those could be avoided. Biopsies, like for example, bronchoscopic biopsies of nodules is frustrating because almost half are non-diagnostic. And then complications occur, especially with like transthoracic needle biopsies. So we're in a situation where we need to make decisions to move forward, but if we have more accurate prediction of cancer or not, we have potential for improved quality of care and cost savings to our healthcare system. So we're going to talk about a combination of tests to improve classification. Next. This is what you might see in advertisements as a reminder: notify lung, reclassifies risk, and reduces uncertainty, designed to quickly and accurately decipher the risk of malignancy with a single blood draw. Next. This is the two tests that make up Notify Lung. On the left, CDT, cancer detection test. On the right, XL2, Back to the left side, CDT, you'll see more detail shortly, but it's a blood-based antibody assay. It's a rule-in test to show the nodules that are more likely to be malignant. For a rule-in test, you need a high specificity, and there it is, 98%. There's a number of publications behind this, and I'll highlight a few. On the right, back to Notify XL2, also blood-based. It's a rule-out test to identify nodules that are likely benign. For that rule-out test, you need a high sensitivity, and there it is, 97% sensitivity. It's covered by Medicare, set up so there's no out-of-pocket expenses for Medicare beneficiaries. And again, multiple publications and presentations for that test. Now, more detail next. CDT, it has a group of antibodies, which I'll talk about in the next slide, but it looks at all cell types and shows, again, the 98% specificity and a good positive predictive value. Next slide. On the left, you see the group of antibodies, and any one of them identified will be associated with an increased risk of cancer, and it's done as a panel. You can see how it performs as far as sensitivity at a 93% specificity, and it is less sensitive to stage. In the middle, you see it's good for early stage disease, and that's a lot of the cancers that were done in this study. Next slide. This is recent data that was just presented at the CHEST meeting this year, shows further validation of the CDT test with a new set of samples. These came from the Panoptic study, which I'll explain more in a few minutes, but over 300 samples, over 250 were usable in the assay as a highly specific test. 34 were positive by this. So that's 13%. Of those, 74% were malignant. So this reconfirms a highly specific test. We will, with an acceptable sensitivity and a 74% positive predictive value. Now, next, we're going to shift to the XL2 test. So this is the high sensitivity with an NPV of 98%. On the right in the pie-shaped chart, we get asked, well, how important is this test and what makes it up? So this test combines two plasma proteins, LG3BP, C163A. Yes, you can look them up. One's a galactin binding protein. The other is related to cysteine. They're tied to cancer or inflammation. So they're looked at as a ratio combined with the clinical factors you see listed with the nodule, smoking history, age, and nodule size. The pie chart highlights that these proteins add 30% of the information in the test results. So it's as powerful a contributor as nodule size. And in my practice, I couldn't imagine managing the nodule without knowing its size. So now I would want to know its protein values too. Next. This is the Panoptic summary and a nice visual abstract put out by CHEST at the time of publication in the fall of 2018. It's an integrated classifier. There's the proteins again. In this study, we focused on those nodules that had 50% or less pre-test probability of cancer as assessed by the solitary pulmonary nodule calculator, also called the Mayo calculator. In that population, 16% were malignant. Here's the specificity and sensitivity again with the high NPV. With clinical use, it predicts 40% fewer procedures on benign nodules and only 3% were predicted to be misclassified, so of malignant nodules misclassified. So this is the essence of the Panoptic study. Next. What happens when you see a nodule and give it a pretest probability? Based on our guidelines, this is the next step after identifying a nodule. About a fourth end up in the high risk of malignancy greater than 65%. The guidelines say these should be evaluated. In the center, the large intermediate group between 5 and 65%, that's almost 3/4 of the nodules seen. And this is where there's a lot of variability in practice patterns depending on your institution. The bottom, risk of malignancy less than 5%, that's not very many nodules. In Panoptic, this was 2%. It varies between 2 and 5%. So here, most nodules move on and don't go to CT surveillance if you follow this by the guidelines. Let's add in notify. What happens to these distributions? So instead of 74%, the intermediate group is down to 47%, and you now have a fourth of nodules, excuse me, going into CT surveillance appropriately. Next slide. This is current data. So on the left, Panoptic study predictions shown as we call violin plots. So pre-test and post-test probability are shown on the left, pre-test, post-test in gray. There you can see visually the shift into the less than 5%. And that's a 47% of the patients are reclassified to that less than 5% risk of malignancy, where you can have increased confidence of that it's benign and can follow with CT surveillance. Now, Panoptic there on the left, we can now say in practice, in the middle in orange is clinical practice, over 500 nodules. On the right, in the more reddish color, is a registry study we're running with over 300 nodules. And you can see at a glance, we're confirming in practice and in using the test, the significant shift of reclassification into the less than 5% for CT surveillance. Next slide. So let's combine the two tests. So here's a flow sheet where you start out with the green box, very low risk, low to moderate risk, 5 to 65, and on the right, high risk greater than 65%. Well, guidelines, high risk goes right into biopsy or surgery. Now we've lumped very low risk and low to moderate because even though what we're seeing, most physicians will say, yeah, it's less than 5%, but they're still uncertain. They know there's a wide confidence interval. So the first test is Notify CDT. That pulls out the patients with the higher probability than 65%, and they move into high risk. Now, the ones that don't have autoantibodies and have a pretest probability of less than 50% go into Notify XL2. Those results come back in 1 week. I need to point out the CDT comes back in 1 day from receipt. Notify, you get that result, that shifts you either to CT surveillance or leaves you in the intermediate where you still go on to further evaluation, PET scans, biopsy, etc. Next slide. Show you a report. So you don't get 2 reports, you get really 1 report. Notify CDT is here. The example shows pre-test 12% risk of malignancy into that low to moderate risk group. That pre-test is used with the CDT result, recalculating the post-test probability. So here's a result with high level and autoantibodies. And that patient now has a 66% post-test risk of malignancy. So you can move forward more quickly. And if it's negative, then you just get the XL2 report. Next slide. Here's an example where it was a 40% pretest risk. You get a likely benign, the most powerful result from XL2, and it goes to a 4% risk. That's personalized with the patient's own pretest risk to get a post-test risk. And there you can more confidently go to CT surveillance and follow guidelines in the surveillance intervals. Next slide. So in summary, where we are today is cancer can't wait. That's been nicely pointed out by Ray. And we've slowed down because of the pandemic. And here we are, it's flared again higher than it even was in March and April. So we're forced to take some risk, but we can manage a lot of nodules with telehealth, telemedicine. So we're balancing the risk of exposure versus delayed diagnosis. Notify Lung can help prioritize the patients, those that should move forward more quickly, and those that can stay with CT surveillance and more remote care. So again, add your questions and we'll have time for questions. I'll pass it back to our moderator.
Thank you very much, Dr. Springmeyer, and to Dr. Jett and Dr. O for the very informative presentations here. As Dr. Springmeyer said, if you have any questions, we're going to spend the next couple minutes here addressing a few that have come in from the audience. So the first one here, I believe, is for Dr. O. Have you seen an increase in nodule patients from evaluation of COVID patients?
Yeah, just piling on to the burden that we bear. Already in the Mid-South, being on the Mississippi River Valley, we already have confounding by histoplasmosis, and we also happen to be in the sarcoid belt of America. So we already had that going. And of course, COVID, being a pulmonary disease that has a wide spectrum of appearance that we're only learning to understand better, has come in as, yes, indeed, one more confounder of the scans that we do. I think that only raises the point that Steve was making, which is that I don't know if I emphasize this enough. It is a giant haystack, okay? There are lots of needles, but the haystack is just humongous. And the problem is we can't afford to tear up the haystack looking for those needles, painful as they are, numerous as they are. And so the need to be judicious in separating between those for whom intervention is needed and the vast majority for whom it is not going to be needed is a huge challenge. And one of our holy grails is to find a reliable means of simplifying that process while squeezing down the duration of time it takes to actually get an answer. Because, of course, this being lung cancer, right, the longer you wait, the easier it is to diagnose it. Unfortunately, that's a losing proposition for the patient. And so what we really need is the technology that allows us to have these abnormal X-rays in a granuloma endemic region, and actually already the future in the instant, to quote Macbeth here, Jim asked which Shakespeare character, hopefully I'm not going to be Lady Macbeth tonight, but to be able to tell the future in the instant is exactly what Steve is talking about. A means of knowing who today is destined for bad stuff tomorrow so we can rescue them in time. I think that's where technology really needs to come and help us out.
Thank you very much. Another question, maybe I'll start with you, Dr. Jett. Do you anticipate that there will be new COVID or society guidelines about COVID for nodule evaluation or bronchoscopy in the coming months?
My impression is a lot of these organizations on their website kind of update their as they go along. So I think the changes are going to vary from place to place. You know, we're hearing that a lot of hospitals are slammed, they're full, their ICUs are full. Obviously, if you got a full ICU and your staff is working, 100 hours a week, you can't put in elective type of surgeries or bronchoscopies or things like that. So I think each place will vary from place to place. But look at the ASCO resource guidelines. I think be new information there coming out regularly.
Thank you very much, Dr. O or Dr. Springmeyer. Anything to add there about anticipating further guidance from societies or elsewhere?
Well, I think they're going to stick with the guidelines to be careful, but what I hear is everybody's starting to moderate. We're in for the long haul. It wasn't just going to be 2 or 3 months. So we've got to take care of the patients. We can't keep waiting.
Yeah, I agree with that. I think we're beginning to see the other shoe drop now. Back in March, when this was around the corner, and all we were hearing were these horror stories out of New York, I was able to talk to colleagues in Italy and Spain and China who ISLC with me. They were able to relay their harrowing lived experience, and so we really clamped down. We didn't want the doomsday scenario in which we did all these elective ventilator dependent procedures, and then you had this horde of COVID collapsing people coming, and you didn't have vents for them. So essentially, we shut down lung cancer surgery for several weeks, and I think one of the painful lessons we have learned is that lung cancer surgery is not really elective. It's not the same thing as having a nice facelift or some sort of other thing, because we're seeing all these patients coming now who, yes, we triage them into other ways. We did things like putting people on neoadjuvant therapy, leaning more on SBRT, giving people immunotherapy as temporizing measures. But I think our anecdotal experience is that as we're getting people to surgery on the back end, we're actually finding that there is a lot of stuff that probably is more advanced than it might have been otherwise. So we're having to temper. Even though the COVID numbers have gone through the roof, we're actually not shutting anything down this time, at least for lung cancer.
Thank you very much. And we have one last question here, which is, Dr. O, maybe we'll give you this one too. In studies where you've looked at delays in lung cancer diagnosis from screening or delays in intervention, have you looked at delays related to the patient? For example, that they're worried to come into the office for the evaluation?
Yeah, so if you're referring to in the time of COVID, right? Cancer care in the time of COVID. Yes, I showed you the reduction in our ET volumes during the time of COVID. Now, some of that was a conscious decision. We de-emphasized screening. But what I also showed you, the reason why I showed that on the slide is our incidental nodule proportions also went down. That tells you the foot traffic was way down. People weren't coming to the ER quite as often as they were. People weren't, guy having chest pain wasn't running to because he thought he was having a heart attack and somehow, somewhere got a chest x-ray or whatever that showed the lesion. Those kinds of things. That's part of what Jim is telling us. We are going to reap the whirlwind over the next few years because all this delayed care is going to come home to roost and we're already seeing the front edge of it.
Excellent. Thank you very much for that response. With that, we'll wrap up the program today. So thank you again to the presenters for taking the time to share this information with us.